Good morning. It's another exciting installment on anal rectal concerns. If you really want to start your day off badly, get up in the morning. Sounds like a microphone's on. Get up in the morning with an anal fissure, and you'll have a bad day, and that's for sure. So what is an anal fissure? It's a tear in the anal canal. And this is how you diagnose them. You look, and so I'm just about through with the talk. But I'll drag on with other stuff. But an anal fissure is plain and simple a tear in the anal canal. And so I'm going to be talking primarily about primary anal fissures. And it's from local trauma. It's usually from trauma with defecation, often change in bowel movements. So certainly constipation is the most common etiology. For some patients, we get fissures with a change to diarrhea. Anal manipulation through intercourse or other trauma can cause fissures, pretty rare causes. So bowel movements are the most common cause of anal fissures. The anal fissures, primary anal fissures are acute and chronic. The 90% will occur posterior in the anal canal, and they usually heal in about a month to 6 weeks with proper treatment. The ones that don't heal or are recurring become scarred, and they become chronic fissures. So a chronic fissure will have scarring around it. Interestingly, and they don't talk about it, I've never seen it in the book, you can almost see it in this picture, there tend to be a little undermining of the distal skin, and I think that helps contribute to keeping them open. And again, chronic fissures will have a sentinel tag, or a patient will think they have a hemorrhoid, and then a hypertrophy papilla, and you can see the internal sphincter at the base of the fissure, the chronic fissure. And then secondary or atypical anal fissures, these are the ones you also have to be very much on the lookout for, because you miss these and it'll really make you look bad. If a fissure is off the midline, get worried and concerned that you're looking at something other than a garden variety anal fissure. And the atypical ones are cancer and inflammatory bowel disease, are far and away the most common causes of atypical fissures. And then I've never seen TB in the anal canal. This is a picture of a Crohn's fissure. It just looks ugly. They just don't look the same. It's not just a little simple tear like a paper cut or something like that. They'll be shaggy and just really look bad. If you see a really funny looking fissure, it's probably a funny looking fissure. With Crohn's, the tags they get will be very edematous and look different, generally be off the midline. And so if you do a good inspection, little lights can go off in your head saying, this does not look like every fissure I've ever seen before. And if in doubt, get some help. And this is the only syphilis anal fissure I've ever seen in this slide, because I didn't see this patient. So if you see one, take a picture, because you're not going to see me. All right, so what causes fissures? Like I said, it's usually the trauma of a bowel movement, change in bowel habits, constipation being the most common, and it's just simple. The anoderm, the lining of the anal canal, gets stretched beyond its bursting point, and you get a tear. Repetitively, they become chronic. The current popular theory is ischemia. The previous current popular theory was elevated anal pressure. Somehow people have done studies to show that there's less blood flow in the posterior anal canal than in the rest of the anal canal, and that the perfusion is inversely related to the pressures in the anal canal. Now, I can read, and I know that's real popular theory and things like that. I'm just simple-minded, and I have a little bit of trouble buying that as a strong etiology. I still think it just burst. It tears. And sometimes you have to accept that. People have done manometry on people with anal fissures. Now, I've done hundreds and hundreds of manometries, and let me tell you, and I've seen hundreds and hundreds and maybe thousands of people with anal fissures, and most people with anal fissures don't want you sticking something up their bottom. And so I've never put a lot of credence in the studies with anal manometry in patients with fissures. They hurt, and is it a chicken or the egg? You know, do they hurt and have high pressures, or did they have hypertrophy anal internal sphincter and high pressures and develop the fissure? So I still don't think that those theories quite answer the question as to why the patient got the fissure. I do think there's a little bit of credence to lack of support in the anal canal. As the sphincter muscle originates off of the coccyx and goes to the pubis, it splits to go around the anus. And so it makes kind of a little triangular space right behind the anal canal. And operating on these people, I can see there's just not as much support posterior as in other portions of the anal canal. So anatomy may just be a significant factor. But it's still trauma nonetheless. What do you see? They hurt. They hurt a lot for most patients. Every so often you'll see a patient with a fissure that just bleeds some and complains of some mild irritation or pain. But more commonly you're going to see patients that have pain that bring adults to crying. I mean, it hurts. So pain, think fissure. It's often pain and bleeding, and as pains worsen with bowel movements, the bleeding occurs with bowel movements, and it'll be bright red blood. The patients will often be constipated, and typically what I see, and I tell patients that it's usually young, healthy people. This is not a problem of diseased people that have lots of other things, immunocompromised or anything. They're young and healthy. They don't eat enough fiber. They don't drink enough water. They have busy life schedules, and they defer having bowel movements and put it off to some time later. And I'm looking at a whole room full of candidates. Let me tell you, y'all are high risk for getting anal fissures. And my advice, drink more water, less coffee, and eat fiber. Y'all realize that coffee is anti-water, so just because you urinate doesn't mean you're getting plenty of water, it means you're getting dehydrated. To diagnose it, look. That's how you diagnose it. You look. Unfortunately, you got to get up close and personal to find anal fissures. You can't look at them from across the room. You've got to examine the patient, get them in a comfortable position, and spread the buttocks. I'm going to tell you, you're going to miss most of them if you have a patient lean over a bed. That may work for urologists doing prostate exams, but that's not how you do an anal rectal exam. If you don't have a procto table, something you put the patient kneeling, lay them on their side so they can curl up, because when you bend your knees and hips at 90 degrees, it helps to relax the sphincters. So you don't look with a patient bending over an exam table. You've not done a visual exam. So if that's what you've been doing, change. Lay the patient down, put them on their side. Look posterior. Often you just see the bottom edge of it. Often you see just a little bit of a start of fissure, even maybe a drop of pus or something. That's all you need. they're tender, they hurt, don't do a rectal exam. Now, I know for the students that down here toward the front of the room and toward the back of the room, you have plenty of folks that beat upon y'all that every patient, if they have an anus, they get a rectal exam. They're 100% wrong. Now, in general, they're right. But just to hurt someone, you don't do a rectal exam. If you can make the diagnosis, don't do a digital exam. We're not in this business to be mean to people. And again, if you see something that looks unusual, lateral, alarms, think about it, something's wrong. And just a hint on when sometimes you do rectal exams, you can't see it. You're still concerned that someone has a fissure, you can do an exam. Advice, when you do the rectal exam, initiate pressure anterior. 90% of the time it's going to be posterior. And so press away from where they hurt, and then you can get your finger into the anal canal, and as you feel, and just briefly feel posterior, and that's it. Quit. You're through. You've done everything you need to do. Go home. But be nice to folks. Sometimes, especially with chronic fissures, but they're not quite so tender, you're able to do an endoscopic exam to look in the anal canal. But most of the time, you can't do a rectal exam, but you can look. So there's no excuse not to look. Differential diagnosis. Last week I mentioned fissures, and these three things cause anal pain. The book puts solitary rectal ulcer syndrome as a differential diagnosis. That's a much different animal patient. They have kind of chronic pain and bleeding, often have a lot of anxiety. Separate, not the anxiety of a fissure, but a different anxiety. You're not going to confuse too many solitary rectal ulcers with fissures. Treatment. For me, treatment is a little bit simple. Remember the young folks that don't drink enough water, don't get enough fiber, defer their bowel movements? Reverse it. Those are the factors you want to change to treat it. The key is fiber. And I'm going to talk a little bit about creams and all in a minute, but it's all moot without fiber. And I would say that I'll be generous. 90% of the patients that show up to me in the office that have been seen by another doctor and diagnosed with a fissure will show up with a cream, but no fiber. Okay? And I mean generous when I say 90%. It may be 103%. And for fiber, patients will ask you, Doctor, how am I going to get fiber? Well, learn how patients can get fiber. And then you can answer them and seem like you know something and you're not the college student from next door. Be a doctor. I had a resident when I was in the Air Force that went to the commissary on base and cataloged the fiber in every single cereal that they had on the shelf. And any of y'all that hadn't been in the military, the commissaries are big grocery stores, and they had everything. And Fiber One cereal, and all brand with added fiber. Now, for y'all that don't know, I'm extraordinarily lazy. Fiber One is much shorter to write than all brand with added fiber. So I peddle a lot of Fiber One cereal. It's 13 grams of fiber in a half cup. A half cup of cereal is not much cereal. Almost assuredly, every single one of y'all eat more than a half cup of cereal if you eat cereal. In fact, if you look, Raisin Bran and things like that, Raisin Bran has more fiber now than it used to, because serving size used to be 2/3 of a cup, now it's 3/4 of a cup. They didn't change the Raisin Bran, they just giving you more cereal and fewer servings in a box. But Fiber One cereal is only a half cup for a serving. It's bland, it doesn't taste bad, but it is fairly bland. So I tell patients to mix it with cereal that they like. They mix it real well with things like Cheerios and Raisin Bran because they already have fiber in them. and add flavor. Put a fourth of a cup of Raisin Bran in, now you've gotten one serving of Raisin Bran. But they can mix it with Frosted Flakes, Lucky Charms, Fruit Loops. I could care less, because 13 grams of fiber is a lot of fiber. If you're aiming for 25 grams a day, you've hit half of it right there. If they mix it with things like Raisin Bran Cheerios, it's just a little bit more. I'm telling Rick Water. Psyllium is Metamucil and Consul. Metamucil has either 3.2 or 3.5, I think it's 3.2 grams of fiber in a dose of Metamucil. Consul has 6. These things are learnable, so learn them. So you can talk to patients, act like a smart person. The Consul is pretty gritty. Dr. Stratton is a big proponent of it. I've peddled a lot of Consul, but you really don't ever want to drink orange juice again once you've started using Consul to mix your orange juice. I think it just ruined it for life. The one word about fiber supplements: don't ever let it sit still. Stir it and drink it, because if you let it sit there, it'll gelatinize. You'll never use fiber again after that. Citracel. It's a methylcellulose. These ferment. This doesn't. You have a patient with irritable bowel, you don't want to be giving them Metamucil, because it's going to ferment, their bloating's going to get worse, and they're not going to be happy, and they're going to quit using it. Use Citracel. So it's not just a one size fits all. Oh, go take some fiber. You better have some alternatives. Benefiber is a real nice one. This is a soluble fiber, no grit. You can sprinkle it onto your food. But the soluble fibers tend to make stools thicker. Benefiber is what I give to patients that have loose stools, and I want to help them have thicker stools. So if you have someone with a fissure, often their stool's already too hard, too thick, so Benefiber might not be the right answer for that patient, but it is an alternative, because it is tasteless. You really don't know that you're doing it. You put it in water, juice, or just sprinkle it on food. And then Fibercon is a capsule. I have never been a proponent of it as polycarbonate fiber fill or something like that. It really sounds like something you put in sleeping bags and ski jackets, so I've never been a real fan of it. But I do have a word to the wise on these two right here. They make a capsule form. Ask the patient, you've been using any fiber? Oh yes. What are you taking? Metamucil every day. How much? 1 capsule. 500 milligrams. Okay. It takes 7 for a dose. So 1 capsule of Metamucil is not fiber. So ask the patient, ask that next question. How are you taking it and how much? So I generally like to get to twice a day on these two. Water, water, water. When I see patients in the office, I explain to them that I'm an extraordinarily lazy person. I absolutely despise to write, and I write water 3 times. That I mean it. And then I talk to them about the anti-waters, the coffee, tea, cokes. Stool softener is a fair game. 99% of the patients and doctors in the world think that Miralax is a fiber. Just because it's a powder, it is not. It's a stool softener. It's okay to use Miralax, but again, Miralax causes abdominal bloating, Surfac, collates things like that better. And sitting in a tub of warm water, remember I talked about doing manometries? There are folks that have done manometries on people sitting in tubs. Now, I have not been part of those studies. But anal manometry does relax. Sitz baths, warm water will relax the anal sphincter. So they can be beneficial. The creams. I use topical anesthetics. They're all expensive, but they're lesser expensive. These either require compounding or Rectal is on the market. They're expensive. Remember talking about poor blood flow as being etiology of fissures and all? So people got the idea that these cardiac medicines for Dr. Hiller would be great to treat fissures. And so they are the hot topic of the day. And there's not a study out there that definitively identifies that they cure fissures better than topical anesthetics and fiber. Now, they provide good pain relief, just like other things, but they're not demonstrably better. But I'm not going to tell you not to use them because, I mean, there are some mixed things. Some things will suggest that they're better, but I'm not convinced by the studies. Most of them I don't think were done very well. Most of them were done without fiber. They'll have a cursory statement, patients encouraged to use fiber. Okay, well, I'm not sure they pound upon them hard enough to use the fiber to tell. Nitroglycerin, one article, the conclusion was that it causes headaches much better than it causes curing of fissures. So it does cause headaches. I've never given anybody nitroglycerin, though it's commercially available now. This one you have to get compounded, 2% nifedipine cream, usually mix it with lidocaine and hydrocortisone. You put it perianal. The fissure's in the anal canal. Kind of a little counterintuitive to me, at least with anal tram and lidocaine hydrocortisone, you can get applicator tips and put the medicine where the pain is. But this is very, very popular today. We have a mail-order compounding pharmacy that we can get this, they'll send it to the patient's house in 24 hours. So nice curb service. Don't give somebody suppositories for an anal fissure, they're already hurt. Again, you're not mad at them. But 90% of patients that come to me, they're given something by a doctor and they weren't given fiber. Most of them show up taking suppositories and they're not happy. But these are the really not happy patients. These are rectal rockets. They're very popular. Compounding pharmacies love them. I get ads from the compounding pharmacies here in town begging me to give patients rectal rockets. They take that little slit and they put nifedipine, hydrocortisone, lidocaine, nitroglycerin, pramoxine, anything you want, they'll put in there. And I have so many patients come to me and says, please don't give me those rectal rockets. But there are a lot of them sold in town. All right. Real quickly, the treatment. Lord's anal dilatation, very popular in Europe. That's four-finger dilatation. Eliza, did you ever see any Lord's dilatation in England?
Yes, sir.
That's the world center of the Lord's dilatation is in England. It successfully tears the sphincter in multiple places, uncontrollably. Don't do it. Are you a proponent?
No, I'm not a big fan.
Botox, it's a current thing. You can go in and have your crow's feet and your anal fissure treated off of the same bottle of Botox because most of the time the patient has to buy the bottle of Botox, so you might as well use it as much as you can. It's expensive. It will lead to temporary healing of fissures, but the vast, vast, vast majority recur after about 3 months, and there's a pretty significant rate of fecal incontinence during the 3 months that it was being helpful because it is just relaxing the anal sphincter. We have not done it. It's expensive and temporary. The gold standard, sphincterotomy, it's a partial division of the sphincter laterally, not posterior. Open and closed methods, works 95% of the time. I talk to everybody about incontinence. Early on, patients sometimes will say they leak a little bit, but if you follow the patients, less than 1% will have any significant incontinence at all. It's really a very safe operation that people get scared away from because it says sphincterotomy. Make a little incision in the anal canal, identify the internal sphincter, and cut it. Close it up. There's a blind approach or a closed approach. I've not been a big fan. do some every so often. You slip a knife in, there are two ways to slip it, because it was under the anaderm, turn it and cut back, or slide it into the intrasphincteric groove, turn it and cut forward. I'm not a big fan of it because the most common way is to stick in the intrasphincteric groove, turn it forward, then put your finger and cut towards your finger. I don't know about y'all, but I was taught not to cut towards yourself. So that's not one of my favorite operations that way. A little controversial, do you cut the fissure out when you do the surgery? For me, yes, unless it's just simply an acute fissure that you couldn't get better. But 99% of the people I operate on for fissures have chronic fissures, they have hypertrophy of papilla, they have external tags, they have scarring. I give them a fresh wound to heal back there, and I think it helps. Some other people agree. Interestingly, they say that does not contribute to incontinence. And then lastly, one of my absolute favorite operations for fissures is I call it a nylon pedicle graft. It is now, even on the self-review studies, talk about it in women, you probably should not be doing sphincterotomies because of concerns with incontinence. If you don't know, with ultrasound studies, ladies, when you have uncomplicated vaginal deliveries, that means no breech, no forceps, no episiotomies, 25% of the time you'll have some degree of a sphincter injury. Two babies, 40%. So a little worrisome about taking formerly or future childbearing women and cutting their sphincters some. So you can do this in women without doing a sphincterotomy. Sometimes the scarring has led to a mild anal stenosis, and you can treat that. And presumably, I don't necessarily buy this, no association with fecal incontinence. Let me tell you, just a simple having a fissure and a scar can cause some minor fecal incontinence because it's a scarred gasket or valve, and they just never work quite perfectly. And again, in this operation, you excise the fissure. I make a U-shaped flap back here. The full width of the defect that I've created, you cut all that out. Cut all the way down through the fat to the muscle, and your blood supplies the underlying fat. Slide this into place and then close, and it works very nicely. And that's what I would advocate in most women that have a chronic anal fissure. And that's it. Any questions? Yeah, Justin.
So, I think I know the answer to this one. On the website, there was a question about an anal fissure, and it said a little like wording to it was that the guy comes in and requests the most definitive procedure for the fissure. That'd be a fistula, right?
Go ahead.
Sorry,
Sphincterotomy, yes. That's what they're looking for you to know, that the gold standard treatment is a sphincterotomy. Any other questions?